Hello and welcome to this lecture about the effects of neuromodulation on visceral pain. My name is Sam EDABE. I'm consultant in anesthesia and pain management at James Cook University Hospital in Middlesbrough, UK. I will talk to you about a number of items listed here: the incidence of abdominal pain, its mechanisms, the literature in SCS, my personal experience, and patient selection. Abdominal pain is a big problem. Over 16 million Americans present with abdominal pain. 2 million of those have persistent pain. Pain is the most common complaint in gastrointestinal clinics and the fourth most common pain complaint in pain clinics. Of course, such a pain will have a strong impact on socio-economic and the lives of those who are in pain. What do we know about visceral pain? It is, of course, poorly localized, referred to somatic structures, and not evoked by injuries to the viscera. Moreover, it produces non-specific responses such as motor or autonomic responses, and we know that it leads to sensitization of body structures like having allodynia over the surface of the abdomen or allodynia of this chest wall. We have come across people who have chest pain referred to the upper limb or to the jaw. This is a slide that shows you the impact of spinal cord stimulation and the way the visceral organ pain is transmitted via the spinothalamic and other tracts up to the higher centers. Here, this experiment shows you that spinal cord stimulation has been shown to suppress the visceral responses to colonic distension in the rat. And you can see the effects, the drops significantly post SCS. So what can we offer people with abdominal pain in the pain clinic? This is a list of what we normally go through, from less invasive to more invasive. What have we used SCS for in abdominal pain? It's been used with a number of indications, several where success was reported. These include mesenteric ischemia, chronic pancreatitis, diffuse abdominal adhesions, etc. This 2010 survey conducted by our colleague Leo Capral and his colleagues reports on 70 cases from a US practice survey where you can see the etiologies of pain were quite varied, from pancreatitis, adhesion, gastroparesis, and unknown. The trials were, as you can see, the majority were midline leads, 21 were paramedian, and 50% were dual octrode. As you can see, the position of the dual octrode there. The majority had undergone a psychological assessment, and some had undergone a multidisciplinary assessment before a trial. You can see that the lead tip position was mostly a T4-5-6 position. Of course, that offers a problem because we know that CSF thickness is at its widest in the T5 level. So if you put your leads at T4 and T5, you will end up hitting a very thick layer of CSF indeed, as you can see here from this cadaver dissection. You will see that you have there a section of CSF where there is quite a bit of thickness, and therefore the current requirements will be quite high. However, having said that, it is clear from this survey that in the successful trial group there has been a considerable reduction in pain, whereas in the unsuccessful trial group, as you can see, no reduction in pain. Well, that's really no surprise because they were implanted and you wouldn't expect them to improve significantly having received no particular new treatment. Opioid reduction is the same. The follow-up was an average of 84 months with 56 patients followed up more than 1 year. Complications, usual rate of revisions of about 10%, and 2 system removals due to dissatisfaction because of other complaints. Here is the literature of SCS in abdominal pain up to 2013, and as you can see, there is a shared outcome in that all of these report a VAS reduction. But there is also a shared problem in that all of these report very small numbers, and you can see that the largest case cohort reports 35 patients recruited. That doesn't mean that all of them had success or all of them were implanted. Also, there is a problem in that every single case cohort reported on a different indication. My experience is that since 1997 we've implanted more than 20 patients, largely some at better quality of life, decreased use of opioids, mostly were implanted at T5 to T7 level. There were frequent replacements of non-rechargeable devices, and we've used rechargeable now for the majority. This is the case notes of a typical patient. They present with quite a large series of case notes. The gastroenterologist will go usually through a large battery of tests, following which a diagnosis of functional abdominal pain. They were given simple analgesics, smooth muscle relaxants, and then over to you after the antidepressants. What do? We give them a pain questionnaire, examine with a view to assessing dermatomal hyperalgesia and allodynia, sympathetic blockade on some occasions, information session, psychological assessment, and then trial and completion of SCS. So in conclusion, despite high therapeutic success, SCS use in abdominal pain remains uncommon, and few studies describe the basic mechanisms. There are still cost issues, payers not approving it because of a low level of evidence. That was the case until 2020, where we have the first prospective multi-center study by Leo Caporal and colleague published in Gastroenterology 2020, and this is a prospective cohort of 24 participants, so not a huge number. Refractory chronic abdominal pain, more than 5 out of 10 on the VAS, and as you can see, these are the patients. You could see that the flow: 33 enrolled, 24 underwent trial, 23 were implanted, and at the 12 months study visit exit, 22 patients had completed the 12 months, with one exiting at between 1 and 3 months because of adverse events. So not a huge attrition rate, but again a very small number complete. Here you can see the results from the pain score, the impact on the pain score, quite remarkable drop from 8.3 to 2.3 at 12 months, and quite a remarkable steady result from 3 months to 12 months. This is again the pain relief in percentages, the number of responders above 50% pain relief, only 4 patients not reaching the 50% pain relief margin. Here is the percentage of responders, and here is the number of remitters below 2.5. This is all quite wonderful, but it is difficult to accept that patients who have had pain all their lives with the attendant biopsychosocial problems that result from having long-term pain would respond in such a fashion for such a period of time, and that this response would actually be sustained past 12 months. Particularly, this is a striking thought when you look at the indications, that despite a varied range of indications here, you have such a uniform and a magnificent response. Before I close, I will talk a little bit about sacral nerve stimulation, not necessarily for pain, but it is a visceral stimulation. The chap you can see here in the picture is Professor Giles Brindley, who made the first sacral nerve stimulation for spinal injuries patients, and these contacts were strapped directly onto the sacral nerves to cause bladder contraction. These are the neuro augmentation or spinal cord stimulation indications in functional and pain disorders, and as you can see, the most common are urinary incontinence and interstitial cystitis. The etiology of incontinence is either bladder overactivity causing inertia incontinence. As you can see here, patient has to rush to the bathroom. Second one is sphincter underactivity, which causes stress incontinence, so wetting of the underclothes when the patient is laughing or sneezing or straining, or any combinations of the above. Just to give you an idea, incontinence is very much more common in women, and it is a very common complaint in adults over 40 years of age, occurring in about 15 to 17%. You can approach sacral nerve stimulation via different routes, the retrograde approach and the transforaminal approach. I won't go on about this because I know you have a specific lecture on pelvic stimulation for pelvic pain, and I'm sure you'll cover these issues. With that, I will say thank you very much, and hope you enjoy the rest of the course.